This podcast is for general informational, educational purposes only and is not to be considered medical advice for any particular patient. Clinicians must rely on their own informed clinical judgments when making recommendations for their patients.
Welcome everyone to our special Journal Club series episodes here on PHM from Pittsburgh. For those of you who are new, we are a continuing medical education podcast started in October of 2016 here at UPMC Children's Hospital Pittsburgh in the Paul C. Gaffney Division of Pediatric Hospital Medicine. We've been coming to you discussing different topics on the American Board of Pediatric Content Specifications for Pediatric Hospital Medicine and some contemporary topics that came up that demanded attention, such as our favorite virus, COVID. Now, one of the areas we were trying to figure out how to cover is the research part of the content specifications. And this has more ramifications than just PHM. General pediatricians, other subspecialties have to know these topics. This is the area where we learn how to critically evaluate the literature. Now, as you can imagine, this is difficult to discuss on an audio-only podcast format. To pull this off, we have partnered with our colleagues at Dell Children's Medical Center and Dr. Philana Ling Lin, who's with us today. And we have a group of experts from the University of Texas at Austin and the University of Pittsburgh. And you're going to meet them throughout this series. And we couldn't have done this without everyone's help. So thank you. Now, just for this episode, we are on episode 9. If you're keeping score at home, we are finishing the common statistical tests like the t-test, ANOVA test, chi-squared, and other nonparametric tests. We went through episode 8 with Dr. Philana Ling Lin, and of course, she is back for episode 9 to help wrap up this topic. So to introduce her properly, Dr. Philana Ling Lin is an associate professor at UPMC Children's Hospital, Pittsburgh, the Division of Pediatric Infectious Diseases. She has a master's in clinical research from the University of Pittsburgh. She wears several hats. She's an accomplished physician-scientist with expertise in the host-pathogen interaction with Mycobacterium tuberculosis and TB-HIV co-infection. She is the site PI of a nationwide multi-centered pediatric study group examining the changes in the seroprevalence of invasive pneumococcal infections in children over the last several decades. As the Pediatric Infectious Disease Fellowship Director, she is deeply committed to the clinical, research, and academic education of her fellows, and now to us. So, Ling, thank you for joining us.
Thank you.
All right, let's do our disclosures, and then we will dive right back into where we were. So I will go first, kick it out to you. I'm on the advisory board at Sanofi for increasing vaccination rate in immunocompromised patients.
And I don't serve on any boards. The pneumococcal surveillance study at one point had some funding from Pfizer, but is primarily investigator initiated out of Baylor. And I do receive honorarium from the National Institutes of Health for peer review studies section. But outside of that, I have no conflicts.
All right, Ling, we're wrapping up this episode. We're getting close to the end of this whole Journal Club series. How are we doing so far?
Good, I think. I'm cognizant of the fact that this stuff comes and goes in one ear and out the other. And so oftentimes we have to sort of keep going back, reviewing the concepts in the podcast, reviewing them right before you take the boards, that type of thing. So I am going to put in some repeated comments about certain concepts so that either you get bored of me or you go, yeah, I know what that is. Because I think that's sort of the benefit of knowing what it is. And if you have any specific questions about some of the stuff I talk about, you might want to go back to episode 8 where we talk about it in detail.
Before you keep going, let's put the plug in. The paper we are using as a base to discuss these topics is Courtney A., Bernard A., Burgess S. et al., Bolus First Continuous Nasogastric Feeds for Infants with Bronchiolitis, randomized trial. This is in Hospital Pediatrics, Volume 12, Issue 1, January 2022. And we have been nothing but complimentary to the authors because they wrote a fantastic paper that discusses their methodology very well.
Right. So the whole point of this paper is bolus versus continuous NG feeds for infants with bronchiolitis. There was a premise that they thought that continuous would be worse than bolus. What they did, so remember, this is a study in Australia in infants who were 12 months or less of age admitted for bronchiolitis who received NG feeding, and they were randomized to receive either continuous or bolus feeds. In the methods section, the authors point out very specifically that the primary endpoint is their length of stay in hours. And they had estimated their sample size based on previous studies and their goal was to enroll about 100 in each arm. If you're interested in the discussion about the primary endpoint, I would refer you back to episode 8. But just to recap, the primary endpoint of the study was length of stay, which we said was hours, and which we discussed was a continuous variable. And then the secondary endpoints were whether or not a patient developed pulmonary aspiration and whether or not they were admitted to the PICU. So if we think about those types of measurements, would we call those continuous data or categorical? And we talked about in episode 8, they're really categorical data. And more importantly, they're mutually exclusive to each other. So in pulmonary aspiration, that's a yes or no. Did you aspirate or did you not aspirate? For PICU admission, did you go to the PICU and were you admitted to the PICU or were you not admitted to the PICU? And so those are mutually exclusive, which makes them sort of easy. The hard part is that you can't think of it like a bell-shaped curve, right? Because there's yes or no. And so these are categorical data. And the way we typically think about categorical data is we put it like in a grid or a table, right? So our tables would have two categories, which is the bolus, continuous feeds, and then yes or no. Did they get pulmonary aspiration? Did they not get pulmonary aspiration? Were they admitted to the PICU? Were they not admitted to the PICU? And so you can't do a student t-test because the distribution of the data are completely different. So the standard for the way these are done in terms of categorical analysis of categorical data are two main tests. And so those two tests are called this chi-square or the Fisher's exact. So the chi-square, and it's CHI. So I guess some people pronounce it chi squared, but chi is really a T. So don't think of it like T. It's a hard C. It's CHI hyphen square. So it's a chi-square test. And basically the goal is to see whether or not the two categories are independent from each other. And so in some respects they're known as the test of independence. So the null hypothesis is that the two are independent, that there's no difference between the two. And so in this situation, what we would say is that the proportion of children admitted to the PICU in the bolus NG group is the same as the proportion of children that are admitted to the PICU in the continuous NG group. Right. So that's our null hypothesis, that the proportions would be the same. Right. So when we think about like yes or no PICU admission, remember that it's of a total number of patients, right? So if there were 100 patients in that arm, the number of patients in the PICU is a proportion from that 100, right? So think of it as comparison of proportions. The difference between a chi-square and a Fisher's exact is that chi-square analyses are used for categorical data or a large sample size, right? So if I have a lot of kids enrolled, then I could argue I could use the chi-squared. But what's a lot mean? And so people have come up with sort of like cheating methods. So the one thing is if you have in your 2x2 table, if you have less than 5 in any one group, that's automatically, to be conservative, automatically goes in the Fisher's exact category. It's not, the sample size is not robust enough to do a chi-squared analysis. Or if in any one cell you have less than 20% of the total. So in that situation, you would use a Fisher's exact. So chi-squared for large sample size, Fisher's exact for smaller sample size for categorical data. All right, so let's just see what they had in this paper. And that, if you look in the paper, if you're able to pull it up, is in table 3. Table 3 to me is like the money table because it tells you the primary and the secondary endpoints. So if we go back If you remember in episode 8, the length of stay was the primary endpoint. So remember again, for continuous data that's normally distributed, it's a student t-test. In their particular situation, they used a test for normality, and it was not normally distributed, so they had to use a Mann-Whitney test. So Mann-Whitney is for non-normally distributed data, comparing two groups. So in their bolus group, their length of stay was 54.25. In their continuous group, their length of stay was 56 hours. And their p-value was 0.64. That means that basically the possibility that these would be different by chance alone, in other words, to reject the null hypothesis, is 64%. That's not good odds, right? If I'm going to bet money, I'm not going to, let's see, if I was going to bet, let's bet something that was unlikely to happen. If I was going to bet that a comet was not going to hit the Earth today, and I was pretty confident that it wasn't going to happen, then I would probably say that there's a less than 5% chance that a comet's going to hit the Earth today, right? And I'd be betting good money on that, right? If my chances were 64%, I would not bet money on that, right? If my p-value is at 0.64, I'm not going to bet money on that. That's not a situation where I feel confident that this is going to happen, right? Am I confident that 56 hours is different than 54.24 hours? No, right? So that's the comparison of continuous data. All right, now let's look at the comparison of the categorical data. First, turns out no one in the study aspirated. So can't really do that analysis. Yeah. But the other secondary endpoint was PICU admissions. And so if you look on that table, there were 11 children of the 98, so 11.2% of children in the bolus NG feed group that were admitted to PICU. There were 26 out of 91 children, or 28.6% of the children in the continuous NG group that ended up in the PICU. That p-value, based on what they did, and they actually have a little notation. They actually did a chi-square test on this, so they felt that their data were robust enough to do a chi-square test. That p-value is 0.004. Oh. Holy moly. So it turns out that there are more kids so the proportion of children that were admitted to the PICU in the continuous group turns out to be statistically significantly higher than the proportion of children admitted to the PICU in the bolus group. Well, that sort of stinks, doesn't it?
If I understand that right, that means in the chance that this difference was of a statistical aberration, or that we just got rare occurrences, is 0.4%. So this really tells us that if you're getting continuous feeds, you're more likely to end up in the ICU.
Well, so interestingly, that might be your take on it. That is actually not the take of the authors, right?
Okay.
So remember that you set your primary endpoint like as your most critical factor, because it's your primary endpoint that you're basically doing your sample size calculation on, right? Mm-hmm. So their primary endpoint, their length of stay is no different. But you're exactly right. It turns out that there are more children admitted to the PICU in the continuous NG group than in the bolus NG group. Now, you could argue, well, see, there's your answer right there. But again, that's a secondary endpoint. And did you control for those factors? In other words, did I choose? So if I designed the study to address whether or not the PICU was really if I wanted to look at the study and take out that variable, what I would actually do is I would say, maybe what I should do is I should randomize the kids in the PICU as continuous or bolus, and randomize the kids outside the PICU as continuous or bolus. That would really be the right design to say whether or not continuous or NG made a difference. I guess you could argue, I guess you could say, no, by doing that, you take out, you're taking PICU admission as an independent variable. Yeah.
Yeah, but you have to do it from beforehand. The sicker, you have to make sure you're not picking the sicker children to get the continuous NG feeds.
Right.
So it makes it hard to make that.
Right. So what this sort of suggests is, did I, somewhere in my randomization, not draw up inclusion or exclusion criteria that would pick out the sickest kids? Right? Did I accidentally choose the sickest kids in the continuous group? And you're right. What you're saying is, boy, not really. It didn't really happen by chance alone. Was there some other confounder that could account for this? But yeah, the one way to interpret it is, kind of looks like the ones in the continuous did not fare better. Like basically ended up in the PICU, which was a secondary endpoint. I will tell you that the conclusions don't say that. What they stick to is no significant difference in length of stay. And that's not wrong. There's no significant difference in the length of stay found between bolus and continuous NG feed strategies for infants hospitalized with bronchiolitis. But they do say the continuous feeding group had a higher proportion of intensive care admissions, and there were no aspiration events. So on the one hand, you could argue, well, if you look at length of stay, it doesn't matter. But if you look at PICU admissions, it might actually matter, right?
Yeah.
And there, and in the author's defense, they do provide, and this is where having a discussion is great, they do provide some question about whether or not there could have been confounders. Yeah. The clinical practice of, so what they do say is the clinical practice of using continuous NG feeding in moderate to severe bronchiolitis remains unsupported. Using bolus NG feeding regimen may best mimic usual infant oral feeding in physiology. I mean, clearly, I don't practice in Australia, but they were clearly motivated, right, to really look at this question in a way that they could. So just to recap, for categorical data, there's either chi-squared. Chi-squared test is for using a larger sample size. If you don't have a larger sample size, then it's a Fisher's exact test. Those are two tests used for categorical data, one for larger sample size, one for smaller sample size. And they're kind of used as the standard, to be honest, for categorical data. There are other measures, especially if you get to larger groups. The larger the number of comparisons you're going to use, or the more comparisons used, the larger the sample size, the more complex types of analysis you need. And that's when you really do need a statistician for your help. You should always be talking to a statistician to make sure that you're doing things legitimately. Not only that, you also need a statistician to help you make the right interpretation, right? Because the statistician is going to help you go through your study design, make sure that you don't have any issues with confounding, make sure that you've set your inclusion criteria, exclusion criteria data. So just to recap this study, what was the question? The question was there a difference between continuous versus bolus NG feeding in children who were 12 months or less with bronchiolitis admitted to the hospital? Their primary endpoint was length of stay, which we figured out was a continuous variable. We usually, as a standard to compare two groups for continuous variables, we'll use the student t-test. However, the student t-test requires that the data are normally distributed. In this case, it was not normally distributed. So episode 8 goes over the fact that they had to use a Mann-Whitney and how that's set up. And the secondary endpoints were categorical data. So presence or absence of pulmonary aspiration, presence or absence of a PICU admission. And for categorical data, we use chi-squared or Fisher's exact. And then at the end of the day, it's really about what was the hypothesis? What was the take-home message? How generalizable were the data? We talked a little bit about the fact that in the United States, or at least in our hospital, it's primarily IV fluid and not necessarily NG fluid. But I would say if you were in a shortage of IV fluids, or as you happen to mention with the hurricane, if you only have the choice of NG, you have data available to you to choose whether or not continuous may be different than bolus. What are the take-home messages? It is very interesting, right? So their primary endpoint was length of stay. But while there's no difference in length of stay, the PICU admissions were higher in the continuous NG feed group. And so what you write in your discussion becomes critically important. They say, and you should always have a paragraph about limitations in your paper. They say at the end, the study did not compare differences in cost effectiveness, for example, or parental satisfaction, for example. So there are always going to be caveats when you actually have to submit your paper. Always just be focused on what your question is, what your hypothesis is, how you set up the design, and what your take-home message is, and make sure that your statistics are not only transparent, but are accurate. And that's probably true for any study, right? The NG study just happens to be nice because it compares two different groups. It's very straightforward. But even the conclusion, as you just pointed out, has some nuances to it that don't necessarily pan out as you thought. Science does not always go by prediction, which is why you do it in the first place.
Yeah. That was great. And thank you to our Australian colleagues for making that study so we had something to base off of. This was great. Ling, this was wonderful.
Thanks, but just remember, you always need your statistics friends. I can only get you so far, right? I think it's important for everyone that does Journal Club to, one, have an expert in the field, right, that knows the area, that knows the literature.
Yes.
And two, have someone who has a good eye on the statistics, right? I can certainly read and know when I need help or not, and that's true for medicine. Know what you know and know when you need help. And then ask yourself, how much, does this article apply to what I do? What I end up doing, we all have Journal Club. I pick an article that sounds interesting. The more I read through it, the more details. And several hours after reading it, I'm like, darn it, I should have picked a different article. So the other lesson is don't just read the abstract. Read the details, but sometimes when you're writing the abstract, make sure that you're accurate on the abstract. They're exactly right? They're right. There's no significant difference in the length of stay found between bolus and continuous, but they do say the continuous feeding group had a higher proportion of intensive care admissions. They're not making any interpretation of that. They're not saying why. They're just giving you the data. You could probably come up with the reasons why that might be true. It also depends on whether or not you are truly dedicated to believing that continuous feeds are better than bolus feeds or vice versa. I might have thought the opposite, but what do I know? Was there a bias in the type of feeding? Because remember, these kids were, the treatment arms were not blinded.
Right.
So was there any, was there any bias towards the kids that were getting continuous feeds? Were they, more likely to enter the PICU for some other reason? I don't know. Right. So when you talk about study design, those things are important. Blinding actually makes a huge difference too. But in this particular case, it wasn't blinded. They knew if they were on continuous or not. It was just randomly assigned whether or not you were in the continuous arm or whether or not you were in the bolus arm.
I mean, to your point, to even create these podcast episodes, we have two different institutions. We have our colleagues in the biostatus in the bioinformatics office and the librarians helping us with all of these episodes and screen these articles. So having experts for Journal Club is super important. And you have done countless hours of research or PI. Me doing this alone would have been comically bad. Just comically bad.
Oh, yeah, I guess we should. I'm sure they make podcasts for, I can't imagine, I guess if I were a good joke maker, I could make jokes about what a chi-squared actually means or something. I don't know. The student t-test legitimately has been, that urban legend I think is actually true. I think it did come from Guinness.
Yeah, I remember Guinness having something to do with biostatistics, which I found just wonderful. Yeah,
and actually, so I guess we can't put in plugs, but there's a lot of clinical done in the era where cancer chemotherapy was actually developing. So if you've ever read, for example, I won't say this, there's a really long and large book about the evolution of cancer chemotherapy. And it talks about the fact that, our statistics didn't really exist. The types of statistics we use now in clinical trials didn't exist until that point, right? So we are commonly, it's not uncommon to develop new science. And with new science comes along new analytical tools. And so you just have to think.
As the old saying goes, necessity is the mother of invention.
Right. And so we will continue to evolve as the science evolves. And who knows, maybe someday someone will look at this paper and say, that was the dark ages of statistics. Who knows?
Yeah,
right.
Maybe.
But it's still important to have an adequate sample size, know what your statistical power is, understand that p-values are simply a probability. There's nothing magical about p-values, and you should never p-value shop. P-values are not FOMO.
Yes. Ling, this has been wonderful. Thank you for episode 9, in the books, in the bag. I can't tell you how much I appreciate your time. Thank you.
No problem. Thank you.
Thank you for joining us for this Journal Club series at PHM from Pittsburgh. We want to especially thank our expert guests for their time.
Special thanks to the University of Pittsburgh for sponsoring the CME for this podcast, and UPMC Children's Hospital of Pittsburgh for supporting this podcast as well. We want to thank our friends at Dell Children's Medical Center and the University of Texas at Austin for their partnership on this endeavor.
Please email my dad at tony.tarchichi@chp.edu with any questions or comments. And as always, thank you for listening!